Welcome to Bloodline Breakthroughs, Innovations and Inspiration. My name is Elissa Baldwin, and I'm the Director of National Patient Education at Blood Cancer United, formerly the Leukemia and Lymphoma Society, and I will be your host today. We welcome you to our video podcast or vodcast and hope you will join us for future episodes where we discuss the latest advances in treatments for blood cancer, as well as hear inspirational stories from blood cancer patients and survivors. On today's episode, we will be speaking to Dr. Brandi Reeves, a physician scientist and associate professor of medicine at the University of North Carolina Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina. She specializes in the treatment of myeloproliferative neoplasms, or MPNs, and leads the University of North Carolina MPN program, which provides clinical and research expertise for MPN patients. Welcome, Dr. Reeves.
Thank you very much. It's nice to be here today.
Well, we are happy to have you. So our topic today is on polycythemia vera, or PV, which is a diagnosis that falls under the umbrella of myeloproliferative neoplasms, or MPNs. Before we get into PV, could you tell our listeners what MPNs are?
Absolutely. So we have a lot of alphabet soup in these particular diseases. So we have MPN, we have PV, we have ET, we have MF. And MPN, or myeloproliferative neoplasms, are a group of chronic blood cancers that are caused by mutations in early blood cells. And so those are mutations that you're not born with, but mutations that happen over time just by random chance. And those mutations, there are three big mutations that cause myeloproliferative neoplasms. They're JAK2, calreticulin or CalR, and the thrombopoietin receptor, or MPL. All of those mutations result in overactivation of a pathway called JAK-STAT. And essentially what happens is then these cells that get the mutations can grow without the body asking them to grow. And so you get what's called myeloproliferation. And when you have too many cells like that in the bone marrow, it can lead to several things. So it can lead to polycythemia vera, or PV, where there's predominantly too many red blood cells in circulation. And that's often measured by hemoglobin, hematocrit, and also red blood cells, or RBCs, on the complete blood cell count. There's essential thrombocythemia, or ET, which is predominantly characterized by elevated platelet counts on the complete blood cell count. And then there's myelofibrosis, where you can have variable blood cell counts, but really the big feature in myelofibrosis is that there's scarring or fibrosis in the bone marrow. And that can lead to lots of symptoms, either high or low blood cell counts. And all of these diseases can lead to symptoms as well as increased risk of blood clots. And so we care in particular about polycythemia vera because there is a quite high risk of blood clots with the disease. And those can be both arterial, like heart attacks or strokes, or venous, like blood clots in the legs and blood clots in the lungs. So about 20% of patients with polycythemia vera are actually diagnosed because of a blood clot. And even after diagnosis, about a quarter of patients can have a blood clot. And those can be mild, like a transient ischemic attack or mini stroke, TIA, or they could be potentially serious and fatal events. And so it's very important that we address these diagnoses when we see them because of the increased risk to patients.
Okay, so how do patients then end up being diagnosed? Do they have some symptoms coming into the doctor?
It very much depends. So it's often about half and half. So some patients will have symptoms or have a blood clot, like we said, for no good reason. And some people will be tired or have weird itching. So especially with a hot shower or bath, they'll have unusual itching. And those are all kind of signs that there might be polycythemia vera present. But about half of patients actually have no apparent symptoms, and they're having their routine clinical follow-up visit, and a blood count is checked, and they have elevated blood cell counts. And so that gets looked at further, and ultimately they can be found to have what's called a JAK2 mutation, which is characteristic of polycythemia vera. What's fascinating to me is even though about half of the patients were initially kind of found at their routine screening visits to have the elevated blood cell counts, in retrospect, many of them had symptoms that they like just dismissed. Like, oh, I
Oh,
was having itching after a shower, but I didn't think about that. Or, oh, my hands do turn white and red and blue. And I do feel full after a few bites of food. But I've kind of always been that way. I've always been a little bit tired, and I just attributed it to I'm very stressed at work. I have kids, right?
yeah.
And so it's actually interesting when you dig into it. I think many patients do have symptoms, but they didn't know that they were really a symptom until that retrospectoscope kicked in.
Oh, yeah. And so you mentioned that the PV patients will have JAK2 mutation. Do they all have JAK2 mutation, or might they have other mutations?
Yeah, so the vast majority, so 99 plus percent of patients with polycythemia vera will have a JAK2 mutation. And about 95% will have one specific JAK2 mutation called V617F. The
Okay.
other handful of PVera will have mutations in a different part of JAK2.
Uh-huh.
But essentially, having a JAK2 mutation is part of what causes polycythemia vera. You can have other mutations as well, but in terms of what we call the driver mutation or the reason for polycythemia vera, it's really a JAK2 mutation that is driving the whole thing.
Okay. Now I'm curious. We know that sometimes the MPNs can transform into a different MPN, or in myelofibrosis case, into AML. Can PV transform into anything or a different MPN?
Absolutely. So, what is sort of maddening about these diseases is they're not static, they're very dynamic. And
Hmm.
so you can actually, if you have a JAK2 mutation, but you initially start as essential thrombocythemia with the elevated platelet counts and not really elevated hemoglobin hematocrit, you can over time actually develop into polycythemia vera, where your hemoglobin hematocrit are increased. And polycythemia vera can progress over time to myelofibrosis, where you have scarring in the bone marrow. And then, as you said, myelofibrosis can go on to develop to acute myeloid leukemia or AML.
Hmm.
Now, in terms of the frequency of that, so in polycythemia vera, the rate of progression to myelofibrosis is roughly 1% per year. And right, that's variable for, depending on what other mutations you have and whether there's scarring in your bone marrow at diagnosis. But on average, it's about 1% per year.
Hmm.
And the risk of developing acute leukemia is about 0.5% per year. So while right at diagnosis, those risks are not huge, you can imagine that over time, those risks really start to add up. And so in a disease where the overall survival is roughly 15 years from diagnosis, and that's if you're diagnosed at age 60, not, I want to make this very clear, if you're diagnosed at age 40, you do have a better prognosis than somebody who's diagnosed at 60. So you need to consult an MPN specialist and don't just consult, for instance, ChatGPT, because you will
Yes.
freak yourself out about mortality risk and overall survival. But you can imagine then that a 60-year-old diagnosed with polycythemia vera still probably has, 10, 15 years of overall survival just from the general kind of population standpoint. So
Hmm.
you're talking then at least a 10 to 15% risk of myelofibrosis and 5% risk or so of acute myeloid leukemia. So the big goal in polycythemia vera, as we're looking at things, is right. You want to keep things either where they are or revert it back to more normal while not upsetting those bone marrow cells into developing into myelofibrosis or the acute myeloid leukemia.
Okay. Really, then, with the older patients, are they mostly just kind of living through the normal lifespan then, versus PV potentially transforming or getting worse?
Yeah. So it really does kind of depend on where you start, right?
Hmm.
And when we talk about the overall survival, it's from the time of diagnosis, not from the time where, the retrospectoscope again, where I had abnormal cell counts
Yeah.
for 5 years, but nobody picked it up. It really kind of goes from when you were diagnosed.
Hmm.
In terms of reduction in overall survival, there is a reduction in overall survival as compared to the healthy general population. And so it really doesn't matter where on the spectrum you are.
Hmm.
There is a decrease in terms of expected survival because of polycythemia vera. But it's still something like high blood pressure or high cholesterol, right? Where it's going to be a chronic disease and not something like an acute leukemia where you can kind of go through the disease very quickly and rapidly. And so when we think about how we're going to manage polycythemia vera, we have to keep that 10 plus year survival in mind.
Hmm. Now, are there different risk stratifications or levels of risk for PV like there are for other MPNs like myelofibrosis?
There sure are. That is less well accepted in terms of how we parse things out. So there are scoring systems for survival in polycythemia vera. Um, what's interesting is even though we have those scoring systems, what we use clinically to decide what treatment a patient gets is not based on overall survival, but based on thrombosis risk.
Oh,
And
okay.
so
So,
that's the
what
risk of
is
blood
that?
clot.
Oh,
Yeah, so
risk of blood
so
clot.
yeah,
Okay.
so that's the risk of blood clots, and that's
Hmm.
because blood clots are the primary cause of death in polycythemia vera.
Okay.
And so, and this is kind of an antiquated risk stratification. So you either age into the club of high risk, so 60 and older is considered high risk,
Hmm.
or you join the club because you get a blood cell clot, or a blood clot. And so you are high risk if you're over 60 or if you've had a blood clot. So you can imagine you're not in the group until you are, which is
Yeah.
really annoying. There are features that can help us risk stratify within that, but that's the kind of the major decision point that we have. Um, and those things are somewhat tied to overall survival, but again, we're not using that overall survival right now in terms of how we're managing polycythemia vera.
Yeah. So, before we get into the current treatments, with PV being a chronic cancer, what is the goal of treatment? Is the goal more of controlling the disease, like you just talked about, in symptoms for a better quality of life, or is it curable?
Yeah, this is a great question. So I would think that from a patient's point of view, the goal is cure, right? And from my point of view, that would be fantastic as well. But right now, our only curative therapy is allogeneic stem cell transplantation. That's where we get rid of your blood stem cells by giving you high doses of chemotherapy
Hmm.
and then give you somebody else's blood stem cells and immune system back in something called an allogeneic stem cell transplantation. It sounds fairly straightforward. And in fact, it is. It's kind of like if you are a farmer and you have a field full of corn and what you're trying to grow is corn, but you've got some weeds in there and you've been through that field and you've tried to pull the weeds and you can't get them. So what you decide to do is burn the field down and start fresh with just corn seeds. That is great, right? But there's a chance that those seeds don't grow, and right, that still things might contaminate your field as things are growing back. Same thing with the stem cell transplant. So,
Hmm.
because of that, there's a fairly high risk of bad events, including death, about 20% chance of death in the first year after transplant. So, for a chronic disease, we don't think that that's an acceptable risk. So, even though there is a curable option,
Hmm.
the risk benefit ratio there really is not in favor of proceeding with a stem cell transplant at this time. Now, technologies are getting better every day, so maybe in the future that risk benefit analysis will be different, but right now, no. So, right now, the goal of therapy in polycythemia vera is really to reduce the risk of blood clots, improve symptoms if there are symptoms, and while not kind of accelerating the rate of progression to myelofibrosis or an acute leukemia.
Yeah. So let's get into the current treatments for PV. So, what are they?
Yeah. So this is also going to sound very ancient and antiquated, but one of the kind of standard treatment options is therapeutic phlebotomy, so bloodletting. It is at least not with leeches, so there is that.
That's nice.
Exactly. But that is just where you have an IV inserted and you donate blood to the garbage can. So Because of this mutation, you're not allowed to donate blood to the general blood supply for fear
Mhm.
that there might be transfer of this mutation to somebody else,
Yeah.
even though that's never been proven. But so that not only reduces your hemoglobin hematocrit, but also reduces total iron, which limits then the nutrients that red blood cells need to grow. So that's one of the main ways that polycythemia vera used to be treated. Um, and that can be done, weekly, every couple of weeks. It depends on the person. So some people don't need that frequent of therapeutic phlebotomy. Other people
Mhm.
need more frequent therapeutic phlebotomy.
So are they getting
Um,
that by just checking blood tests and CBC and everything to see kind of what their levels are at?
exactly. And we like to keep the hematocrit less than 45%.
Okay.
And that's based on now a study from 2013, which also seems ancient at this point, called the CYTO-PV study, where they were randomizing polycythemia vera patients to maintain a hematocrit of less than 45% or 45 to 50%.
Mhm.
And the study was actually stopped early because there were excess cardiovascular events. So that's blood clots in the higher hematocrit group. So there were 4 times more cardiovascular events in the high hematocrit group. And
Oh.
so this is where we get this classic maintain hematocrit less than 45% in polycythemia vera. So that's one big goal. Now, we typically only use therapeutic phlebotomy as a primary treatment if a patient's considered low risk for blood clots.
Mhm.
And so, if a patient, however, is considered high risk for blood clots, we are going to advocate for something called cytoreductive therapy. So that means that we're going to use a drug to try and keep the blood cell counts normal or at least close to normal, and certainly the hematocrit less than 45%. And right now, so we have hydroxyurea, which is kind of the main workhorse in this cytoreductive category. So that's a pill. It's pretty well tolerated. It's pretty cheap. It works pretty quickly to lower the blood cell counts. It's been used for a couple of decades now with
Mhm.
pretty good effect. The problem with hydroxyurea is that it's not fixing the blood stem cell problem, though. So
Oh.
it is non-specifically reducing all of the blood cell numbers, and while that's translating to less blood clots, it's not really doing anything favorably to the bone marrow.
Mhm.
And so you still have that risk of progression to myelofibrosis and acute leukemia over time. It also increases the risk of non-melanoma skin cancers,
Oh.
which here in North Carolina turns out to be a really big issue.
Yeah.
And so we keep an eye on that very closely, and it can limit the use a bit of hydroxyurea. There's also interferon therapy, so
Mhm.
interferon alpha, and the FDA approved option is called Ropeg interferon alpha 2B, or Besremi is the trade name.
Mhm.
And so that's not so cheap and not a pill. So it's an injectable under the skin that you give yourself every 2 weeks. And it also lowers the blood cell counts. But the big difference between this drug and hydroxyurea is that this drug can actually decrease the number of the mutated cells in the bone marrow.
Oh.
And so, in the PROUD PV continuation PV study, which was ropeg interferon versus hydroxyurea, so the standard of care in polycythemia vera, ropeg interferon at 6 years actually had fewer events than did hydroxyurea. And that was a combined endpoint of blood clots, of progression to myelofibrosis, and progression to acute leukemia. And
Mhm.
that was all tied to the reduction in the JAK2 positive cells. And so we're now getting into the realm of being able to provide what we call disease modifying therapy for patients. So
Mhm.
not just reducing the risk of blood clots, but right potentially then delaying the progression to myelofibrosis or acute leukemia. We're still not talking about cures at this point.
Yeah.
So some people are getting into very deep responses, but we're still not talking about cure with this. But there's a lot of interest in combining this with other treatments to see if perhaps we could get to a curative state. And then there's probably a drug that most patients have heard of. So because of the JAK mutation, um, JAK inhibitors have been
Hmm.
used in polycythemia vera. And the JAK inhibitor that is FDA approved for PV is called ruxolitinib or Jakafi as the trade name. And
Hmm.
so that it's approved as a second line therapy for polycythemia vera. So in the setting of if you didn't tolerate hydroxyurea or hydroxyurea didn't work for you. Now, Jakafi is also expensive, but it's oral,
Hmm.
so it's easy to take. It's generally well tolerated. It very quickly reduces blood cell counts, which is great. And one of the big benefits of ruxolitinib or Jakafi is that if you have itching, it's a really great itching drug. It's also really great at improving symptoms like night sweats and having a big spleen. So
Hmm.
those are all benefits of something like ruxolitinib. Downsides to ruxolitinib, though, are cost. It does suppress the immune system just a bit,
Okay.
and it does also increase the risk of non-melanoma skin cancers, which, again, here in North Carolina is a big problem.
Yeah.
Now, curiously, a couple years ago, Claire Harrison's group from the UK reported on the MAJIC PV study of ruxolitinib versus best available therapy. So, whatever the investigator thought was the best therapy for the patient.
Hmm.
And these were in polycythemia vera patients who had previously been on hydroxyurea or interferon and were not getting benefit from those drugs. And so, what was important about this study, it also had long follow up, so 5+ years, and is also showing a reduction of JAK2 mutated cells, and also showing what we would consider disease modification. So there is potentially as well disease modification with something like ruxolitinib, and again, that's different than hydroxyurea. So again, pretty
Yeah.
exciting. And those are really the standard therapies that we
Hmm.
have. We used to use something called P32 radiation. We really don't use that much anymore, but you might see it mentioned in old textbooks. There's also something called busulfan, which is a low grade chemotherapy that we use in low doses that we can use if we don't really have anything else.
Hmm.
But that's not going to be a standard polycythemia vera treatment.
Would that be more if patients may not be responding to any of the other treatments then?
Exactly, or if for some
Hmm.
reason they couldn't get the other drugs, like they didn't qualify for them because of something about their particular health case, or financially we weren't able to get those.
Yeah. You mentioned that the JAK2 inhibitors are a second line therapy. Are there possibilities to move into frontline?
So I think there are, and it's a great question. And one of the concerns, though, with long-term use of JAK inhibitors, again, are the kind of the secondary cancers,
Yeah.
because it does suppress the immune system. And it's not just hitting the JAK2 mutated cells with the current JAK inhibitors that we have. And it turns out that the JAK pathway is important in lots of different cells in our body, so including
Hmm.
immune cells, which are important not just for infection, but also for cancer surveillance. And so, yes, there is. I will say we're all a bit cautious in
Hmm.
terms of what would that mean. So if you're going to be on a drug for 20 years, right? Like what happens with 20 years use of that drug?
Yeah.
It is a great drug from everything that we have seen, and we have patients who have been on these drugs for well more than 5 years. I will say we have seen some pretty aggressive skin cancers with patients treated with ruxolitinib. Whether or not that's exactly because of ruxolitinib, right? Not clear, but
Hmm.
there is a signal out there. So every time we're talking about a drug that's going to be 10+ years of use, you have to think about what's going to happen at 10 years.
Yes.
So
Yes.
I think it's really important as we think about trials and whatnot that we not just think about how it's doing in the short term. It's really, this is a long term drug. How is it going to affect me in the long term?
Yeah, that is very good to find out how it's going to affect people in the long term, and I'm sure that's something that patients want to know. Now, let's talk about the future of
Yeah.
treatments for PV. Are there any emerging therapies or clinical trials that you're particularly excited about?
Yeah, there is some really interesting science that has happened over the last decade in terms of understanding how PV comes to fruition and how, in spite of many patients having iron deficiency, how the body is able to make more red blood cells even when there are scarce resources available. So, iron is very important to red blood cells. And
Mhm.
in the normal situation, if you are iron deficient, you are going to become anemic. So, you're going to have low red blood cells because you can't pack them with iron. And so, your body
Mhm.
is going to say, whoa, I can't do this. In the setting of
Yeah.
polycythemia vera, however, essentially almost everybody becomes iron deficient with therapeutic phlebotomy or just straight out of the gate. And those patients are able to maintain production of red blood cells. And it turns out that is because those mutated red blood cells actually make a signal that rob the rest of your body of iron. So it redirects
Mm.
all the iron kind of to themselves. Isn't that amazing? So
No.
it's like diverting funds from the rest of the body.
Yeah.
And when it does that, right. So the rest of your body becomes iron deficient, but your red blood cells have enough iron to continue making themselves. And so, over the last several years, there have been therapies that kind of affect this iron handling pathway,
Mhm.
and they've been called iron rebalancing therapies. So, I call them Robin Hood because it's sort of, like redistributing
Yeah.
the funds.
Yeah.
And so one of those drugs has actually undergone phase 3 clinical studies and is now at the FDA for consideration of approval for treatment of polycythemia vera. And
Mhm.
that drug is called rusfertide.
Okay.
So rusfertide is what we call a hepcidin mimetic. So again, what it's trying to do is rebalance that iron. So take it away from the red blood cells and see if it can then sort of distribute it to the rest of the body.
Mhm.
Um, in the phase 3 Verify study, about 300 polycythemia vera patients were randomized to receive either rusfertide or placebo. And this was in conjunction with whatever standard therapy they were on. So it could be hydroxyurea, it could be ropeg interferon, it could be ruxolitinib. It just had to be a steady dose of that medication.
Mhm.
And these were patients who needed therapeutic phlebotomies in spite of their standard treatment. And so at 32 weeks of treatment with rusfertide, which is again self administered under the skin,
Mhm.
nearly, I think it was 75% of patients treated with rusfertide did not qualify for a phlebotomy in that 32 weeks, versus it was about one third of patients on placebo. And in
Mhm.
terms of keeping the hematocrit of less than 45%, that was roughly 60% of those on rusfertide and about 14% of those on placebo. And
Mhm.
really exciting was that not only did it cut the need for therapeutic phlebotomy, because it's like, well, I mean, I can have therapeutic phlebotomy, right? That's fairly cheap. But the exciting thing was that symptoms were improving. So iron
Oh.
deficiency is associated with tiredness.
Yeah.
And with this particular therapy, fatigue or tiredness improved with rusfertide treatment as compared to control.
Mhm.
And so that's really big because that's one of the big symptoms that patients complain of. And so that's really encouraging in terms of maybe finding a therapy that improves quality of life in our patients. I will say though, in terms of thinking about the long-term risks of drugs, while this is great at controlling the hemoglobin hematocrit and negating the need for therapeutic phlebotomy, making people feel better, I don't think we fully understand yet what's happening to the iron once it's taken away from the red blood
Mhm.
cells. So the mechanism by which this drug works should theoretically trap iron in in cells, and so theoretically, when that happens, you can cause a condition called hemochromatosis. So you can get iron that deposits in organs. And you
Oh.
can imagine iron is a metal, right? And if you get too much iron in an organ, it becomes stiff and then it doesn't work well. And the primary organ that goes to is generally liver, but things like the heart and the pancreas, skin can also have iron deposition, kidneys. And while we have several years of follow up on these patients with no safety signal that I've seen, again, we're talking about decades of use potentially for some patients. And so right now, where I see a drug like rusfertide until I see better safety data is this sort of short term use where I'm
Mhm.
going to use this as a bridge until your other therapy kicks in. And maybe you don't need then therapeutic phlebotomy and you don't have to get super tired from iron deficiency. But I'm taking a cautious approach in terms of
Mhm.
I'd like to know more about where the iron goes and what it's doing after 5 and 10 years time before I take out therapeutic phlebotomy entirely and just put everybody on rusfertide.
Yeah. It sounds at least like a good possibility for at least a short-term treatment to get things a little bit more regulated, and then maybe continuing on that research. So that is really exciting, though, that it has reduced symptoms, and that sounds wonderful. Are there any other emerging therapies that you're excited about?
Yeah, so there's a lot in that rusfertide category of iron rebalancing therapy that are
Hmm.
in clinical study, all meritorious. Um, there is also coming up, I can't say a whole lot about it, but there are agents that are going to be targeting really just the mutant stem cells. The way that they've been designed looks like they're going to leave the healthy stem cells alone.
Oh.
And so then we start getting into the precision medicine era in
Hmm.
myeloproliferative neoplasms, which is super exciting because in the cousin diseases, so ET and myelofibrosis, um, antibodies directed against one of these driver mutations called calreticulin have really been very exciting. And so we're going to start seeing some of that in polycythemia vera coming up very soon. So super exciting. Keep your eyes peeled for these new therapies.
All right. No, I did want to ask because, a lot of our patients have heard about CAR T cell therapy bispecifics. Are those things that might be a potential for PV?
Yeah. So right now, those are more in the myelofibrosis space
Hmm.
and a little bit in the ET space. So targeting the JAK2 specifically has been a bit more problematic because, again, it's found in a
Yeah.
lot of healthy cells.
Yes.
Um, and so there are kind of things in the pipeline, but nothing that's out there right now in clinical
Hmm.
development in terms of like T cells or bispecifics for polycythemia vera. But know that there's some really cool stuff coming. And I will say, we were talking about this earlier, but it's really important. So a lot of this science has really unfolded over the last decade or so. So it was only in 2005 that the JAK2 mutation was discovered, and that really broke open the field of studying myeloproliferative neoplasms. And after the JAK2, then the MPL or MIPL mutation and the calreticulin mutations were discovered. And really, therapy has changed dramatically in the last decade. And there are so many cool potential improvements on the horizon where, again, we've gone from simply bloodletting to then having hydroxyurea and having possibly disease modifying therapies. And, we are potentially on the verge of not just disease modifying therapies, but right precision therapies that might put us in the space of something like chronic myeloid leukemia or CML, where targeted precision therapies like imatinib or Gleevec have really transformed outcomes in that
Yeah.
disease. And it's really important. Science right now is hurting. So research funding has been incredibly problematic
Mhm.
because of cuts to the budget, government shutdowns. There's a lot going on. So it is highly important to advocate for ongoing research in
Mhm.
these fields because it's exactly this research that has fueled the progress to this point. And we're getting close, right, to making really big breakthroughs. And so let's not stop. Let's keep this momentum going and not having a 40-year pause and be
Yes.
talking about this exact same thing, right? 40 years from now. We're so
Yeah.
close to moving it forward.
Absolutely. And, with the work that Blood Cancer United is doing with both, raising funds for research, but also our public policy team, our advocacy, if you visit the link below, you can see about how to get involved as a patient advocate where patients can share their stories and caregivers as well. And so that you're not just a number on a page, and you can share how much this research is so important to you as a patient, that we need more research. We need this to continue on. And you're right. You were talking about JAK2 inhibitors, really only patients being on them maybe 5 years. And you could see how new this is and how much research has changed the whole field of blood cancer treatments. And it really is so important. So I hope that patients take a look, go visit the link. They make it very easy to contact your state and federal legislators to really share your story and make a difference in this field so that we can get those grants funded through the, NIH, the National Institutes of Health, or through, university grants, and doing what you do right there in University of North Carolina to be able to have that research. So it is so important, and I'm glad that you brought that up. And then on the other side, you need patience. So patients, please look into clinical trials, and there may be a potential treatment that could work really well for you that you would be able to get in on. You can also visit our link below that has our clinical trial support center, and you can contact a clinical trial nurse navigator that can look at clinical trials all around the country to see what you qualify for. So definitely look that up and potentially join a clinical trial that may just be the right thing for you. But thank you. I'm so glad that you brought all of that up. Now, our final question today, Dr. Reeves. This program is titled Bloodline Breakthroughs, Innovations and Inspiration. How do you envision the current or future treatments we talked about today changing patient outcomes?
Yeah. So, if precision medicine really becomes a thing in polycythemia vera, you know, we won't have to worry about all the adverse effects from the drugs that we currently have. We won't worry about suppressing the immune system and developing skin cancers. Patients won't have to worry about developing myelofibrosis and acute myeloid leukemia, right?
Mhm.
And for heaven forbid, like, we're not going to have to worry about blood clots. It's so exciting again to be on the precipice of what will be precision medicine in this disease, given just how little we knew about it 20 years ago.
Yeah.
And, we lumped these things. We didn't quite understand why we made these clinical distinctions. And then we found the
Mhm.
mutations. And then it became clear that our clinical observations matched up with the science. And now right, we're getting medications that line up with the science. And it's so exciting. And I, I envision actually that hydroxyurea and therapeutic phlebotomy, which have been the mainstays of polycythemia vera treatment, are probably not even going to be in our lexicon in
Yeah.
15 years,
Yeah.
which would be amazing.
Yeah, absolutely. It really is amazing how much things have changed and how bright the future is looking with possibilities. I'm very excited to see where we go with research and new treatments, and hopefully those targeted treatments that you talked about today. But thank you so much, Dr. Reeves, for joining us today and telling us all about polycythemia vera and the possibilities for the future and what's going on right now so they can look into current treatments. We encourage all of our viewers to, listen today and take these things back to your doctor and have a good discussion to find out what the best treatment is for you. And thank you to everyone tuning in to our latest episode of Bloodline Breakthroughs, Innovations and Inspiration. Visit the link below for more information on our topic today, and we look forward to seeing you next time.